So good afternoon all. You were all waiting for Dr. Abhishek Srivastav. I was also waiting for him for the debate, but his flight got cancelled and I have to be here on his behalf to do debate on is pharmacotherapy alone cause sustainable weight loss or not. So let me have the poll from the audience that how many of you use pharmacotherapy as well as lifestyle modification for the management of diabetes and obesity. I think all using both pharmacotherapy and lifestyle modification. How many of you only using lifestyle modification?
No.
For ourselves, yes.
So we all give the poll in my favor that only lifestyle modification cannot help. We need to have pharmacotherapy. And if we do pharmacotherapy, there is weight loss. That weight loss increase confidence of the patient that they can cause further weight loss. There will be relief in symptoms. There will be improved glycemic control, improve complication rate, improve in satiety control, and thereby they can have sustained and long-standing weight loss. So first line itself says that sustainable is not permanent. We are talking about sustained weight loss, that is maintain clinically meaningful weight loss while pharmacotherapy continues. We all accept that diabetes, obesity, hypertension, they all are chronic disease. So why we should discriminate when hypertension, dyslipidemia and diabetic requires lifelong therapy? Then why obesity we think that giving therapy for 4 to 6 months and then if we can discontinue the therapy and then patient will not regain the weight. Let's discuss about that. So obesity is a chronic disease, progressive disease, and it is a relapsing disease. So we have to give the therapy for the rest of the life. And yes, lifestyle modification will be the zero or first step for the management of obesity. But without pharmacotherapy, there will not be permanent or sustainable weight loss. So obesity is not only willpower of the patient that they are not enough motivated to do lifestyle modification. It is not just an error in lifestyle modification. It's a chronic relapsing neuroendocrine disorder that requires pharmacotherapy for reduction of weight and maintenance of the weight. It is driven by hormonal adaptation. Hypothalamic set points play a very important role in satiety as well as in hunger. There is a metabolic slowing with age and the reward-based eating pattern that is called hedonic eating. They all are very important and they cannot be changed by behavioral therapy. We have to have the biological thing to fight that. And if we use the biological thing like tirzepatide or semaglutide, we can have meaningful weight loss which can be sustainable for prevention of many complications. Why obesity fits itself or why obese patient become more obese? Because there are hormonal storm in the body that are not regulated like insulin resistance, leptin resistance, hyperinsulinemia, the inflammatory hormones that are secreted from the fatty tissue, lower energy expenditure by the body, they all leads to perfect environment where patient is start gaining weight and also the obese patient is also gaining more and more weight. Why lifestyle modification alone fails? Because as I already mentioned that this is a biological failure. This is not only a behavioral changes. There is ghrelin rise, leptin fall, resting metabolic rate drops, energy efficiency improves with the help of this molecule, and because of that we can have sustained weight loss only with the help of pharmacotherapy. We can see the demographic data that now we are having lesser and lesser underweight population and more obese population, and now it is alarming for us that many pharmacotherapy will come, dual agonist, triple agonist and many more will come in future that will help us to reduce the weight, not only reduce the weight but maintain the weight. Whenever we stop pharmacotherapy, only lifestyle modification will not help. Patient definitely regain the weight because the hormonal changes in the body, they work in that direction that the metabolic rate slow down, the appetite increase and patient will eat more and they will regain the weight that they have lost with the pharmacotherapy. So how pharmacotherapy sustain weight loss? The pharmacotherapy works because the target is not behavioral changes but target is a root cause, that is a biological change in the body, that is a hypothalamic set point, also energy expenditure as well as a fatty tissue or adipose tissue in the body. The set point reset, the game changer, the hypothalamic modulation with the help of pharmacotherapy helps us to reduce the weight, also the sustain the weight, because the patient will struggle with the the only lifestyle modification, they will lose 3%, 5% weight loss, and after that weight loss, their motivation goes because they cannot go beyond 5%, and then they again start gaining the weight, and that is the failure of the lifestyle modification. How pharmacotherapy sustain weight loss, that I already mentioned, that prevents metabolic slowdown with the pharmacotherapy. There is a sustained appetite suppression, there is improved hormonal value in terms of decrease insulin hyperinsulinemia, decrease in the leptin sensitivity, and also we treat with pharmacotherapy obesity as a disease per se, not only a disease of willpower failure, but a disease where neurohormonal dysregulation is there, and you correct that with the help of pharmacotherapy. Let's talk about clinical evidence that sustained weight loss with the pharmacotherapy is not temporary, because we can have more than 20% of the weight loss with the pharmacotherapy that is not possible with lifestyle modification. And if we continue this therapy, we have continued or maintained that weight loss. Dr. Piyush and Dr. Mayur make my job easy in the previous discussion that they will continue tirzepatide for the rest of the life. It is not a short-term therapy that after 6 months you reduce 10% of weight loss and then you stop. The trial and data shown by them, they clearly demonstrated that if you stop the therapy, they will definitely regain the weight. And in those patients also lifestyle modification was there, but despite of lifestyle modification, stopping of pharmacotherapy will regain the weight as it was before the pharmacotherapy. The magnitude of weight loss, how much is enough? If you lose less than 5% of the weight, there is only modest metabolic benefit. But if you lose more than 5% of the weight, there is a beneficial effect in terms of hypertension reduction and blood glucose reduction. With more than 10% of the weight loss, there is a significant increase in the insulin sensitivity, there is hepatic fat reduction, and we have remission of blood pressure as well as diabetes. And more than 15 to 20% of the weight loss, that we can also reduce the cardiometabolic risk because of the hypertension, obesity, as well as dyslipidemia. And this kind of weight loss is possible only with the help of pharmacotherapy. So let's talk about hard data. The magnitude of weight loss, the lifestyle alone can only cause up to 5% of the weight loss. Older drugs were capable, but they can only reduce the 5 to 8% of the weight loss. But modern incretin-based therapy like semaglutide and tirzepatide have more than 15 to up to 25% of the weight loss, which is clinically meaningful and achievable in a real life. This is a semaglutide chart that shows that as compared to only lifestyle modification, the graph shows so much change, up to 17% of the weight loss is possible. And with the tirzepatide, the graph widens even more, and up to 22% of the weight loss is possible with pharmacotherapy of tirzepatide. So let's talk about real world adherence. Most of the time we say that patients do not continue the therapy that given to them. But ask me, if this debate was given to me in last January or February, I would not take. But in last year, with the use of semaglutide, tirzepatide in many patients, up to 500 patients, we have used that. And now I can say with the confidence that patients do not stop therapy on their own. Even when we say that you have 10 or 15% of the weight loss, and if you want to discontinue or reduce the therapy, we can do it. But patient wants the therapy to be continued. They want their weight at a lower and lower border, and they continue the therapy. So the real world is saying that if you reduce the weight, the reduction in the weight will increase the confidence of the patient, their knee pain will go on, their appetite is not there, they definitely eat very less, and this is how they maintain the weight loss. Discontinuation therapy is mostly used as a threat. कि सर दवाई बंद कर देंगे फिर वेट का क्या होगा. But we have to talk with them that दवाई बंद करनी ही नहीं है. It's a chronic disease and you have to continue the therapy for rest of their life. With the time constraint, I am skipping some slides. But in the end, I would say the cost is the only mental problem, not only for the patient but also for the doctor. If you are getting many benefits with the reduction of weight and many future complications, we have to prevent that complication, because the preventive therapy always seems expensive until the complication arise. With that, I would say thank you, and over to Dr. Malai.